Okay.
So, all right, we will move to the next speaker, interventional MRI. So I am presenting Professor Francesca Sanguineti for the interventional MRI, the future of this technique. Please go ahead.
Hello, can you hear me?
Yes, but
Yes.
we cannot see you. Yes, we can see you. We can
Okay,
see you.
Welcome.
great. Good morning, everybody. So I'm going to present to you something about the future and something that we are very proud to go here in Massy. Can you see my screen?
Not yet. We can see you, but not the screen or the slides.
Okay.
Can you share your screen?
Yes.
Not yet.
It's coming. It's coming.
Voilà.
Perfect.
We can see the slide, but can you
Here
put
we
it
are.
in full screen, please? Yes.
Okay.
It is, I think.
Yeah.
Okay. So, no, it's not going. Okay.
It is.
No. Cannot understand.
It's okay.
Yes, but the second is not.
We
cannot
lost the
understand.
slide again, Francesca.
Yes, I'm trying to restart.
I think it was okay, Francesca. You just have
Yes,
to
but
click
it
on
was
the...
not the right one. I cannot understand why.
Ah,
Not yet.
Okay.
Non, on n'a pas l'écran.
We'll try to restart.
You can tell us your lecture of yesterday, which was missed. Terry, can you tell her to have also her lecture of yesterday, which is...
no, it's not the same lecture. It was Antoinette Nilon, but it was too late, so that's why we had to cancel.
Yeah.
So it's not from Francesca.
But we don't have the screen yet.
It's coming.
Ready?
Yes, it's coming.
Yes, okay.
Okay, so why the interventional MRI? Because we are now able to do incredible things in a cath lab and also in electrophysiology. And we can do a coronary, we can do ablation, we can do right pulmonary catheterization, we can do endoprothesis for vascular disease. But we have anyway some limitations. The first one that is we are using X-ray and we cannot visualize directly the cardiac structure around. So this is cannot allow us to see exactly what we are going to go and what we are exactly doing about the anatomy structural which are surrounds our coronary, in example. And we use contrast injection to orient our manipulations, and this can be difficult for some patient with impaired renal function. So the idea is to match the cardiac MRI spatial and anatomical resolution. These are some images that we are all now seeing in our daily practice. So with the exactly anatomical identification of all the structure, and the idea is to match them with the percutaneous treatment techniques that we already know and that we already use. So how to do it? We can do it with daily practice scan. This is our scan in Massy, is 1.5 Tesla, and this is the scan that we use in our daily practice for the 5,000 exams that Jerome presented to you in the previous presentation. And we use, of course, some dedicated sequences, because what we do in MRI is that we do the acquisition, and then at the end, we quickly are able to see the reconstruction built by the scan, but we are not able to do at the same time. So we need to have some real-time sequences that they are dedicated and that are being invented and for this kind of procedure. And of course, you need a display which has to be MR safe, because we have an eye magnetic field inside the room. And of course, we need, like in cath lab, an activation system, but instead to activate X-ray, you can just activate the machine. And of course, we need a special and dedicated material for an ECG interface recording system and for hemodynamic recording system that also displays invasive blood pressure. Of course, all these materials have to be MR safe. And these are us during the first procedure we performed in Massy about 2 years ago. And you can see the environment is the MRI environment, but all the sterile materials that we use in cath lab. But of course, without protection, which is much comfortable for the operators. And how to do it? So what about the materials? So we have some materials that are too simply MR safe. So plastic catheters, in example, swan guns. So these are not metallic, so we can use safely in the MRI environment. But we will see later, it is quite difficult to identify them. So in particular, an example, to identify a swan guns catheter, we have to put inside some gadolinium to be able to see it with the MRI images. Or you can have some that we call active materials. So there are guide wires with a small integrated radio frequencies receptor, which is connected to the MRI scan and which allows to, you can see, to generate a signal which allows us to detect and to move the catheter in real time. As you can see here, so we can follow the catheter manipulation. And there are also some passive materials. What is the passive materials? We just use the principle of a super paramagnetic coating and the artifact principle. So if we put a paramagnetic material in the MRI, we generate some artifacts. And so with the coating, we can just identify it and move, for example, the wire through the anatomic structure. And I will show you some examples later. And when, so we can say in this case that future is now, because it is already the reality. And there are some publications of cases performed with animal studies, but also in the human, and in particular for the right heart catheterization, which it is something simple to do, and also to verify and to check the safety for this kind of procedure is, of course, is essential. So this was the first procedure which was used for this new type of interventional cardiology. And this is our study that is running here in Massy in ICPS. We are going to just evaluate 35 patients with indication to a right heart catheterization, in example, pulmonary hypertension, constrictive pericarditis. And this protocol is built in 2 steps. The first one is the MRI guided invasive pressure measurements in all the right chambers, exactly what we did in cath lab. So to measure the pulmonary artery pressure, the wedge pressure, and in right ventricular, and so on. And the second part is the standard CMR acquisition, so the left ventricle and the right ventricle volumes and the ejection fraction, and in particular the cardiac output is not measured with the thermodilution like we do in cath lab, but that's just using some fleximetry sequences which allow to study the cardiac output through the flow into the aorta. And then, of course, we look for pericardium disease and for late gadolinium enhancement, which can justify a particularly pathological condition. So the advantage is that the patient has a very completed exam that, for me, is almost always going to give the good answer to the question of a clinician cardiologist. And I will show you here some images so you can see this is one of our exam. You can see we can just put the gadolinium into the Swan-Ganz balloon and advance it through the right heart and up to the pulmonary artery. You can see there are 3 perpendicular plants of work that we use, and we are in contact with the technicians outside the room, which is going just to manipulate and orient every section plan. And you will see here the pulmonary artery with its 2 branches, and you will see here the balloon coming with, you will see, and I will show you better, the artifact generated by the wire, the dedicated wire. So we are going to see some artifacts. You can see here some black artifacts, and then the balloon will follow, and we can choose if orient it into the one or the other pulmonary artery, or check, in example, the wedge pressure in the 2 branches. But what we are not able to do in cath lab is to choose it instead to perfectly orient. You can see the balloon coming here and perfectly orient when we want to go. When we stop our intervention is just to have measurements and then to talk with the technicians, and then we can restart like in a cath lab, and just restart our machine and go on with the exam. And here I can show you the pullback and for the pressure measurement. So you can see the balloon coming from the pulmonary artery, and we can see it coming down in the right ventricle. So then we stop, we take time to do our pressure measurements, and then we orient again, looking for our section. This is a very useful in MRI. We can orient the sequence and the section plan as we want. I'm sorry, it was not the right one. We restarted the same one. Okay, this is the one I wanted to show you. Okay, the balloon in the right ventricle. You can see the image that will restart moving, and the tricuspid valve, and then the balloon comes back in the inferior vena cava. So the second part is, this is a standard part, so we can measure the volumes for the left heart and have all the value indexed for the body surface area. And again, for the right one, we compare also the presence of some shunt, in example, which can be at the basis of the pulmonary hypertension. So this is a really complete exam, which just it is coupled to the measurement that we can perform without X-ray and just with MRI guidance. And as I told you, instead of thermodilution, the phase contrast flow study for the cardiac output is used for the calculation of the pulmonary resistance. And I have here some more images to show you, because in the video it is not easy to see it. I think the first time we are looking to this kind of imaging. And you can see here some imaging of the gadolinium balloon of the Swan gans in the right ventricle, in the infundibulum of the pulmonary artery, and the artifact generated by the wire. So we can we just try to avoid to exit the wire outside the balloon to do not be too much aggressive, and we can just orient the tip without exit the wire, or decide to advance the wire, but of course seeing what we are doing and carefully do this maneuver. What about the clinical perspective? Because actually we are just running a protocol for to demonstrate the safety and the feasibility of this kind of procedure, but we are of course talking on something more complex and of course of therapeutic, because we just need something to that was simple, like the right heart catheterization, to demonstrate that the environment of the MRI is safe. But we of course are thinking for what will be the future for this kind of procedure. So the electrophysiology, this is, I think, a field which will be very interesting in interventional MRI, because we can identify the arrhythmogenic underlayer in real time and just orient our ablation, in example, to treat it. And of course, guide also all the invasive maneuvers like the transseptal puncture, because we can in real time identify the anatomic structure and our materials. And of course, use, you can see here, this was of course in animals, but you can see the needle for the transseptal puncture with the right atrium and the left atrium, so we can identify exactly the anatomic structure. And you can see here what it is very interesting also for rhythmologists is to see the post-ablation lesion, because the problem is that sometimes they cannot go too much deep in intervention when they are ablating, because it is a risk, but sometimes it risks to be unuseful. So this is something very interesting. We can exactly identify and visualize in real time the lesion from the ablation procedure and evaluate it. Other perspective is the peripheral angiography. I believe that in this kind of technique, but for the anatomic resolution, we are not at the level to be ready to treat the coronary artery, in example. But for bigger arteries like the aorta or the iliofemoral axis, I think we will be able to be ready in the next future. And then you can see just some example of artifacts generated by the endoprotheses, which have been put in place in this preliminary study. And of course, it is very important to use MRI in special categories in which X-ray are very dangerous, potentially very dangerous, like the children. So you can see the first coarctation treatment in a child, and again watching the paramagnetic passive artifact and the active one to localize the prothesis and to put it in place. And the last clinical perspective is to guide the endomyocardial biopsy. This because with the X-ray there is no difference between the normal and the pathologic myocardium, so it is very difficult to have some effective prelevement by the biotomy. So the idea is we cannot see where we go. So if we can see the X-ray biotom and the MRI, the one used in MRI, exactly the same tools, just it is thought to be used for an MR safe use. And we need, of course, an antenna for the shaft visualization, but the tool is exactly the same. And it allows to visualize the lesion we want to study, and then you can see just the materials, and we can orient our manipulation. And then thank you very much for your attention.
Thank you very much, Dr. Francesca, for this futurist lecture. And for sure, I think the big problem actually is the clinical practice of this type of procedure and the learning curve. So I think we have to have specialist cardiologists working a lot on these procedures to have the experience, right?
Yes, it is right. I've had a big chance in my professional life. I am in a center in which I can do a lot of MRI and a lot of cath labs. So I really share my time between these two procedures. So it is easy for me to orient in the sequences and of course in the procedure in cath lab. But I think for the future, every center will need just two practitioners working together. So one who is oriented in the MRI sequences and can just obtain the good images, and the interventional cardiologist that will just learn to guide his manipulations on a real view of anatomic structures instead of the contrast that we use in cath lab.
Yeah, for sure. The positive points, less contrast, less X-rays, all these are very positive points. Do you have any question, Dr.
Yes,
Salah?
yeah. Well, just I want to ask you about the time. It is the procedure is the time much more than in cath lab?
Yes, of course, I cannot hide that when we start something new, it takes a little bit more time that in cath lab. We are, of course, we have been facing a lot of problems, some technical problems, and also we have just to find the good way to do things. But also in cath lab, it is sometimes difficult to reach, in example, the wedge pressure, and it takes time. So the same is for MRI. It depends also for the anatomy of the patient. If the right ventricle is very dilated, it's of course more difficult. And it is, of course, something different from the cath lab to just train our mind and our eyes to look for the gadolinium balloon and to give time to orient it. It is, of course, different. It takes a little bit more time, but I think it is just because we are at the beginning.
Also, all the material will be adapted to the MRIs, the wires, and like you said very clearly. So it will need special material, to be special companies that will give you all this material.
Yeah, I thank you for this question. Yeah. This is a very important point because it is, of course, there are two ways to solve this problem, but the industry and all the MRI worker are focused on this problem. Two ways to solve this problem. The first one is, as we said, to find the materials which are compatible and safe in MRI. But this is very complex, because if we just think how many here and how many work we did to have materials adapted and perfectly built for the cath lab, it is, I think, impossible to restudy all of them for an MRI safe use. But there is another way to go through this problem, and we are already studying it, is just to try to adapt the MRI sequence to these materials. So, in example, lowering with a magnetic field a little bit lower, and with some less intensive radio frequencies waves. So we are working on it, and I think that if we want to go fast in a universe without X-ray, we have, of course, to do everything we do in a cath lab, but just be able to do it in an MRI environment, or it will not be so easy to go ahead.
It's really fantastic to hear this lecture today. But my opinion, it's a place of CMR, live CMR will take a place especially in the era of structural heart disease. The most strategic point for me especially is the use of cardiac MRI in biopsy, myocardial biopsy. It's very important and very strategic, because actually the ununiform pattern of the disease of the myocardium. It's locate the disease and guide my biotome to take a biopsy. It's for me, it's a very strategic point.
It's patchy. One is patchy always.
It's very strategic point.
Dr. Mohammed?
I think I add to this. I think this is. I'm sorry to say this is to be very in practice to do this intervention MRI in our country. This is very expensive. So I think in being in special situation, like for example a CT guided biopsy for the radiologist, here we need to a biopsy, because I'm from the generation who did 20 years ago endomyocardial biopsy, and now it's vanished. We don't have this, but it is still we have some complication at that time. So I think this time now for myocardial disease to do this with intervention MRI, because it's difficult to do it now with the cath lab. But regarding the Swan-Ganz, it takes 2 minutes to go with the Swan-Ganz to the pulmonary artery. It's not so difficult for us as an intervention cardiologist to do this Swan-Ganz. The second, that for arrhythmia, I don't know that I'm not arrhythmogenic intervention, so I don't think that also it's be easy to ablate or to do something like the cath lab. So do you make a comparison between the time, the duration, the cost, the experience between the ablation in the MRI and the ablation in the core lab? How can you to differentiate? Because it's not so easy for us.
Thank you very much.
It is actually in Massy, we are not working on it. The first part for us is to demonstrate the feasibility and the security, the safety for the MRI environment. This is why we choose to start with the right heart catheterization, and of course it takes probably a little bit more time than in cath lab, actually, because we are at the beginning. So, but it is a way to start, because we cannot start with something which is complex and therapeutic. So this was in a so particular environment. So I have not comparison for the ablation, but of course the idea is to use again what the system of localization like cartography, and to be able to use it of course in an MRI environment to guide the procedure and just check at the end the results, to be able to complete what it is lacking. I think the idea is not to completely replace what we are doing in cath lab or in electrophysiology, but it's just to add something which is actually lacking in our structural, in example, procedures or electrophysiology procedures. We want just to be more effective and more safe for our patient. This is the idea, but we want not to replace the technique and reinvent the interventional cardiology. It's just a sort of matching of the two.
Thank you, Dr. Francesca. Professor Salah?
Just I want to ask about the congenital heart disease. Is any trial to do some procedure like balloon dilatation, closure of ACD, or like this?
Can you help?
Sorry.
Can you help for structural congenital heart disease?
Yes, I think for what it is bigger, this is why I was telling you I'm not sure that we are ready for coronary artery disease, but for all the big structures, so they include the structural artery disease and of course also the congenital and the DDC for the aortic coarctation. This can be, I think, a quick step for a
Dr. Terry, je vous laisse pour conclure. I leave you, Dr. Terry, to conclude this session, please.
Oh, thank you. I would like to thank very much Francesca for this great talk. Of course, we are in the learning phase of interventional MRI, but I think it's really the future. So I think she gave you a test of the future in interventional cardiology with MRI. Jérôme Garraud also showed that, and Jérôme is very humble, so he didn't told you that at that time we are doing more than 5,500 cardiac MRI every year, and we'll probably double next year. So we are doing a lot of MRI, and we are very happy with that because there is no radiation, and we have very precise information, not only for coronary disease, but also for functional evaluation of the myocardium. And the first talk from Thomas with CT was also very important because we are doing at that time 2,500 cardiac CT every year, and we'll probably double next year also. So I think it's really a very important field that we should not forget when we are doing interventional cardiology. So we'll be back at 12 o'clock for the structural session. I think you will see that we will have a lot of very nice talk. Thank you very much.
1 o'clock in Cairo time, okay?
Yeah.
And 12 in
absolutely.
France time, okay? Thank you very much, Dr. Terry, and all the speakers.
Bye.
Bye.